Welcome to the Go-To Physio Show. Coming up on today's show, we take you through a real-life groin pain or adductor pain assessment and how to make sense of the symptoms to prescribe that perfect treatment plan specific to that patient. I also take you through some nice, easy mobilizations that I use day one post-injury with a groin pain patient, as well as sharing some of my biggest secrets to how we've been able to grow our private practice. Along with that, we also have Carl Morris back to help you make sense of your patient's story and get the most out of every single session with a patient so that they adhere to every single exercise. I hope you enjoy the show. Okay, so welcome again to episode 9 of the Go-To Physio Show. Now this week I want to focus more on a groin assessment. Okay, now again, we're not, just like the other episodes, we're not going to cover a full assessment here, but I just want to bring your awareness and try maybe just help improve the higher level of thinking of what we're actually looking at when we're going through assessments. Okay, rather than just, again, as I said in previous episodes, just going through the motions and not having that higher level of thinking when getting all these clues, because the patients are giving us so much clues, okay, when we actually when we assess them. It's just sometimes we don't have the awareness, we don't see it. Okay, so with our groin assessment, the injury history is very important. Okay, so again, I want to know, why is these maybe adductors taking excessive load in the first place? Okay, so again, is there anything in the injury history that maybe that person is maybe not happy to tolerate load in certain directions throughout the body, these adductors to do too much? Okay, so that'll be the first thing. Okay, the other thing then with the generic objective assessment, I want to know what tissues that person subconsciously is not loading maybe very well. Okay, again, in the mentorship we've got this pretty much systemized so that it's very easy to figure out that information. Then when we get them onto the bed, just a couple of things now that I'm going to go through in a little bit more detail. Okay, we want to have a good look at their movements, and again, one in particular, obviously the hip internal rotation flexion is pretty important. Okay, so again with Pete here, we've got a little bit of resistance here. Okay, so as he comes up, the point at which the resistance comes on, okay, there's probably going to be some tissues that are going to be contributing to that stiffness or whatever you want to call it, more so than others. So at this point of the movement, if I feel the resistance here, Pete's posterior hip capsule, it's not going to be fully lengthened at that point. Okay, so I'm thinking more outer layers here. Okay, what has to lengthen at this point? Okay, so again, these distal fibers of glute are going to really start to lengthen at this point, okay, as they attach into here. So if I want to desensitize anything here, I may be thinking I'm going to start there rather than going straight to my Mulligan belt and starting trying to mobilize the hip capsule. Yeah, you might get an indirect response to the glute max, but from my experience, we'll get the person in an hour later. Okay, they'll go to the gym or they'll go to a meeting. I'll grab them, and again, I'm lucky from being in a professional sports setting for so long. I'll grab them, I'll check it again, and usually it's back to square one. Whereas if we go directly, we desensitize these tissues, we reassure the system is safe to tolerate loading, to lengthen, whatever you want to call it, then the gains tend to stick. So again, we want to try just be a little bit more clinically reasoning rather than just trying to throw crap at the wall and hoping something sticks. Okay, hip internal rotation, again, getting the difference between that and supine and prone. Okay, so again, in hip flexion, adductor magnus is going to lengthen. When we check Pete's hip internal rotation and prone, his adductor magnus is going to be short, so that's probably not going to influence his hip internal rotation as much in prone. Okay, so again, that's good information for me, and I can start to use this information and start to clinically reason a bit. Okay, another big one that I like doing is obviously the abduction. Okay, if they feel pain or where they feel this pull. Okay, where do you feel that, Pete? Okay, in the groin. Now again, you may get some athletes that feel it in a very specific spot in the Again, that to me would be maybe these tissues aren't happy to lengthen at this particular point. Okay, why? Okay, again, we want to ask that. We want to check the difference with both of them. Then we can go on to other tests that you might use. You can go do your neural test if that's what kind of therapist you are. That's fine, absolutely do that. Some therapists might look at the lumbar spine, etc. And then the big thing we want to look at then is the motor output through the adductors. Okay, so usually there'll be three kind of angles of hip flexion that we'll do this. Okay, so we'll usually do it at 0-ish. Okay, so I usually get a fist, I'll put it between the medial condyles, and Pete just squeeze for me. And again, I'm looking for intent here. Okay, so at this point, then we'll bring him up to 45 degrees, and Pete squeeze for me. Okay, good. Any pain with that? Okay, and then I'll usually bring him up to about 90. Okay, squeeze again, Pete. Good. And then any pain there. And if there's a big difference noticeably in one versus another, then that's brilliant information for us. Okay, if all of them are painful, okay, then we're going, okay, maybe we just want to be concentrating on desensitizing the adductors as part of our 20% that we're going to focus on treating the symptoms. Okay, 80% of our focus and our attention is going to be on what contributed to this pain experience in the first place. Okay, but the big thing here, the nice thing about this is we can start to reason. Okay, so we know from the literature, okay, that 45 degrees when we squeeze, that's a position that's going to recruit the adductors the most. Okay, when we're in this position, we're going to shorten adductor magnus a bit more. Okay, and then as Pete squeezes, the other thing that we may want to consider here as well, potentially, that I think is pretty important here, is the medial aspects of the direct fem as well. So those tissues in the frontal plane may contribute to this as well. Okay, so again, we can cross-reference that. If we think that's a particular structure that we want to take care of here, we can cross-reference that with other tests as our assessment goes through. Okay, then the big one that I'm interested in especially is 90 degrees, and I always like to go a little bit more past 90 degrees. Okay, so as Pete goes up here, okay, I'll get Pete to squeeze, okay, and then I'll usually get him past 90 and I'll get him to squeeze again, okay, and I'll look at the difference in that. Now there's a few things that's changing in structure here that's important to realize with hips and realize with groins, and that's the influence of the pelvic floor and the diaphragm at that position. So a lot of athletes, especially, they're very poor at the 90 degrees or slightly past the 90 degree position. Now when I bring Pete's knees up, okay, if you bring your knees up here, Pete, what's going to happen here is obviously we're going to posterior rotate the iliums. That sacrum is going to tuck under, okay, but what needs to happen there is the pelvic floor needs to ascend. Okay, so can that pelvic floor get out of the way? When that pelvic floor gets out of the way, then hopefully all these other tissues such as the obliques will be able to actually contract. So again, those obliques are going to be able to contract with ribcage depression. Okay, ribcage depression relies on the diaphragm to lengthen, the diaphragm lengthening and the pelvic floor ascending. They're going to go together, okay, based on, we know this from the literature, especially looking at the respiratory literature. Okay, so again, if this person maybe doesn't like depressing the rib cage, we'd start to think about the optimal length-tension relationships for these obliques and other tissues. And I find clinically myself personally that up here we're more looking at the obliques, or the other big thing here, we want to have good hip flexion. So maybe he's got a poor squeeze here because he's got a poor ability to actually get his hip up into flexion in the first place. Okay, we know about agonist, antagonist, that influence. Okay, is that actually influencing his squeeze here? So very often I can restore full range of motion in this hip very quickly, or this hip or whatever it is, recheck the squeeze, happy days. Okay, so again, the key thing then I want to do is keep that, and that's where my 80% rehab is going to be important. Where if he was there, if he was really strong there, okay, and he was really strong at 45 and he was really weak here, then I want to make sure that all these tissues, okay, that maybe are going to lengthen here are maybe a little bit more desensitized. Okay, so again here, the proximal rect fem, I want to make sure that these tissues are tolerating load very well, that there's no protective tone, or there's no kind of perceived threat to tolerating load here. Okay, and again, it's a simple test that I could do to maybe cross-reference that is hold it there, Pete, push up into my hand, okay, because what I'm going to do here, okay, is I'm going to push through Pete's leg, he's going to have to dorsiflex, and then there's going to have to be load tolerated through this knee as well. Because as I go like that, I'm trying to flex his knee, so he has to tolerate load well through here. Once that comes, keep going. Then as I continue to push, he's going to have to resist hip extension, so he's going to have to flex from here. Okay, so we know we're going to put a load through here. Okay, so that test, it's testing everything, not just one particular tissue. Then I can get a little bit smarter and go, okay, maybe that anterior medial direction is not tolerating load very well, so let's start to bias that a little bit. Okay, Pete, let's have a look here. Okay, and then that's more lateral, and then let's go here, or sorry, that's more medial, and then we can see that he isn't tolerating load very well here at the moment. Okay, if that was the groin pain patient. Okay, so that may make a bit more sense then why this squeeze is maybe down, but this one is very, very strong, because at this point here, these tissues don't have to lengthen. Okay, so they're maybe not perceiving a threat. Because again, remember, when these tissues lengthen, any tissue that lengthens, they're going to set off receptors. That's giving sensory information up to the spinal cord that may potentially go up into the higher centers if there's maybe enough of it going up and the higher centers pays enough attention. Okay, so that's something that I would use then to clinically reason what tissues I am going to treat in order to restore that squeeze. Okay, so that's very, very important to be able to figure out what tissues are contributing to this pain. So if Pete has got a different pain experience from 0, 45, 90, brilliant. That's where we have to use our clinical reasoning to actually go about then figuring out what peripheral tissues are contributing to an inability to do this motor task that we're asking them to do. Okay, so again, it's not just adductors, it's not just obliques, there's lots of tissues moving. When I bring that hip to 90, past 90, I guess that posterior tilt, that pelvic floor needs to ascend. Okay, if it can't ascend because he's stressed, okay, maybe that's contributing to this. Okay, so again, that may be in his history where he's had a lot of loading, either emotionally or physically, and that may have contributed to maybe these tissues not being as pliable, okay, as possible, or as possible, I suppose is the right word there, if it is. Okay, so that's pretty much what I wanted to cover with the groin assessment. Okay, it's not by no means a full groin assessment, but hopefully that'll give you some information. The other thing that I want to talk about a little bit then is if some patients, okay, that you're going to get in, especially in sport, is they'll have a very strong squeeze, but they'll have a painful squeeze. Okay, so in that scenario, so Pete, if you go to 45, again, we've had this quite a bit where they're painful, but it's very, very strong. So again, if they've got a very, very strong squeeze, that's interesting to me. So Pete may say to me, yeah, I get the pain just around here in this adductor. Okay, so what I would do in that scenario then is I like to actually assess some hair then. So I'll just do one adductor at a time, squeeze Pete, and again, it'll still be strong, okay, but he won't have any pain. So what I would then hypothesize there is that maybe this tissue, when he has to do both together, is maybe doing too much. So then I'll go back to this one and I'll get him to squeeze. Okay, so push again, and then usually we may find that there's actually an issue loading these tissues here. Okay, so when they do it bilaterally, sometimes I can see that they'll get a pain experience. Then I'll do it unilaterally, and that pain experience will tend to disappear. So then what I would hypothesize that maybe that tissue there is doing excessive load to do this task, because this is the task to the brain. This is the outcome I want, squeeze. Okay, the brain doesn't really care, okay, how we do it. It just wants to achieve the task. How we figure out what to load, okay, that's going to be going down through the different parts of the spinal cord, the peripheral tissues, and it's going to be influenced massively by our previous experiences to these tissues. So if he had a decreased motor output through this adductor, then what I want to know then is, why isn't he tolerating load well through here? Do I have to trace it down? Do I have to trace it up? Is it still a reaction to the pelvic floor and diaphragm? Is it a stress response maybe? Okay, maybe all I need to do is get him to relax. Do a little bit of desensitization of his respiratory system, change his heart rate variability, get that diaphragm moving a little bit more rather than just that constant fight or flight, and maybe that might take care of it. Again, that just depends on your system that you use. You can look at that. Okay, as always, a disclaimer, this is just one way of looking at the body. This isn't the only way of looking at the body. I'm giving you an insight into how I look at it, my thought process of this 80-20. Okay, and as I said, most of these injuries, okay, overloading, the first question in my mind, what's not doing its job? Okay, so we still respect the pathology, we still want to desensitize, we still want to reassure, we still want to make sure that that pain experience dampens down. But first and foremost, to me, I want to make sure that what maybe contributed to this overloading in the first place is taken care of, because that's then where I can send my athlete back, and I'm pretty confident that that pain is not going to return again, or that another motor adaptation happens and they start to tolerate load maybe excessively somewhere else in the body, and then maybe an Achilles starts to get a little bit sore, or something else. Okay, so I appreciate it's not for everybody, this. It's a different way of looking at the body to how I was taught at university. I've had to start to look at it like this because the traditional approaches failed me when I went into professional sport. And as I said, the more that I started to look at it like this, started to clinically reason, and started to work with hypothesis, where I'm trying to disprove my working hypothesis, okay? Kept to a constraint-based approach where I'm just trying to go at one thing at a time, continually to load. So then the next step, the next progression is the next logical progression. It's served us very, very well, especially in the last 5 years or the last 10 of working in professional sport. The more we start to get an understanding of how the body is all working together, how the respiratory system can impact the musculoskeletal system. Okay, so again, they all have to work together in the real world. Emotional stressors, physical stressors, lifestyle stressors, okay, it all impacts on that pain experience. This is your usual stretch where you're just going to lengthen the adductor. Now, the adductors obviously are going to continue the fascia, etc., the skin, etc. It's going to go across the body. So one way that we can lengthen this adductor, decrease our protective tone, is to use our hands. So as I go into that stretch, what I might want to do then is actually lengthen that adductor more by just reaching this hand this way. Okay, so that's going to lengthen the tissues a little bit more in the transverse plane. Okay, so if you think of sprinting, as I drive through, okay, as this comes through, that adductor is going to lengthen with the hip extended in the transverse plane. If I want to do a little bit more hip extension in the sagittal plane, I'm just going to put the foot slightly forward, go back into that stretch, and now I'm going to get a little bit more almost hip flexor type adductors. Okay, so that's a transverse plane. If I want to really drive it more in the frontal plane, I can just do this. So that's going to get a lot more. I can feel that protective guarding a little bit there. And then if I really want to increase it, I can just put my hand up, and then that's going to really lengthen it in the sagittal plane as well. Or I can combine the two actions, or I can get a little bit of transverse plane, a little bit more sagittal plane as well with that. Okay, so there are some options for your athlete. That's a nice little kind of warm up before they go back into their session. So again, tomorrow night I'm going to be doing a lot of that just to help that tissue lengthen in any which way, because it's usually this position where, you know, if you're rugby or you're Gaelic and they really have to twist, that's usually what will kind of irritate the groin, so to speak. Okay, so that's just some options. I want you to give those a try. And I want you to think about other ways that you could maybe lengthen these tissues and decrease the protective tone. You know, something that I talk a lot about in the mentorship is, and what I'm going to start to talk a little bit in the new grad side as well, is the power of the breath with this. So if I'm doing this kind of movement and I'm lengthening that tissue, the one thing that I want to make sure that the athlete's doing is breathing. Okay, so I don't want them to hold their breath and really rag it. Okay, we want to give it a non-threatening stimulus. So that's where, as you inhale and you reach, you might be able to get a nice lengthening as you inhale there. So as you inhale, that's just going to encourage the brain, combined with the breath, to show it that it's safe. Okay, so again, I might use some nasal breathing, or we might use some other different strategies as well, just to make the athlete's nervous system feel safe. Okay, the last thing you want to do is put them to end range and then just start ragging it. Okay, because again, you want to consider what's that athlete's nervous system thinking when that is actually taking place, where it's a very smooth movement. I'm just going into it for 2 seconds. then it's a very non-threatening stimulus. So I want you to think about that as well with all your rehab exercises. Is that athlete's nervous system seeing this as a threat, or is it seen as reassurance? Okay, so all I'm doing here, I'm reassuring the ability of these tissues to lengthen in pretty much all different planes. So try that for the adductor. And again, you can pretty much do this for the rest of the body, and over the coming weeks and months we'll start to explore some other different variations as well. So welcome to this week's Build Your Business tip. Now this week what I want to talk about is the importance of actually tracking the patients that you're getting from an initial assessment and you are discharging. Okay, so when I say you are discharging, that doesn't mean that your patients are discharging themselves. Okay, so if you've got a lot of patients that are coming in for 2 to 3 sessions, and then you find that actually you feel that they probably need 1 or 2 more sessions, okay, but they've almost, giving you the old, okay, I'll see how it goes, like we talked about last week, then you may actually have a problem somewhere else. And usually that problem is actually in the subjective assessment, okay? But actually recording and having the stats there from an initial assessment down to a discharge, the stats don't lie, okay? And then you can actually take action. And again, it just brings your awareness to a problem in your business, okay? So again, there's a big difference between the patient saying, I feel great, I'll let you know how I get on, versus you actually going, you know what? Now I am happy for you to be ready to be successful in life doing X, Y, or Z, whatever their ideal outcome is, okay? Because it's the patients that we discharge, okay? We are happy that they've earned the right to go back to those things, whereas there's nothing worse than a patient going, oh yeah, I feel great now. You know in your own heart and soul that they need a bit more loading or a bit more tolerance to certain loads, okay, and then their pain comes back, they flare up. Then they'll go, oh, what did you think of Dave, or what did you think of their clinic? And then naturally the response will be, yeah, they're okay, the pain went away for a little bit, but then it's come back again, okay? That's the one thing that I absolutely cannot stand, okay? And I don't, I've got a real passion about, when someone comes into my care, I have a duty of care to do every single thing I can to make sure that this pain does not come back again. And very often that's the bit, that final couple of sessions where you can take them to that extra bit of load, and that's usually the part that we skip, when they go back into a high stress, high load situation, and then naturally then will revert back usually to their movement habits, movement behaviors that they would have done pre working with you. Okay, so have a look at your stats. The stats don't lie, and see, are you doing more discharging, or are you having patients self-discharging? Okay, it's a really good exercise. It'll give you a lot of information. It'll direct your attention a lot now to where the problems are in your business, where you need to focus a little bit more attention on, to make sure that you truly can become that go-to therapist who discharges patients, knowing full well that you will be getting long-lasting results.
My name's Rory O'Donnell. I work in Limerick and I'm a physical therapist. I suppose it was kind of putting a plan together for people, really. They'd come into you and you were quick to diagnose and quick to treat, but then I just didn't have a plan to bring them forward. I had to get them out of the trouble, I suppose. I think I saw it online. I think it was a Facebook post from Dave, and I just signed up to get more emails from him, and I had a chat with him then, and I suppose I liked what he was saying, and I liked the approach. I now have a plan, basically, which is great. You get somebody in, you can do all your testing, see what's wrong with them, and then you have an end goal in sight, and you have that plan, so it's good. Probably the content, actually, I wasn't really expecting the level of content that we got, and it's all superb. It's all really good stuff, usable stuff. I suppose again, you get results and you get them quickly, but apart from that, they stay. You're not when you do discharge a patient, you know, you don't have them back in 2 or 3 weeks going, it's flaring up again, because you know in your head that, you know, right, we've done everything now, this should stick, you know. Do it, yeah, it's great, it's really made a difference for me, and it's well worth it.
The Therapist Mentorship Program was put together to help you accelerate your ability to have confidence and clarity with any patient that comes through the door. It's a very intimate 90-day experience where you work closely with myself and my most trusted therapists to put together a very specific structure in your assessment, your treatment and your rehab for every single patient, so that you can truly get the results that both you and your patient deserve, so you can become that go-to therapist. If you want more information, just click on the button below this video or go to thegotophysio.com/mentorship. We're back with another episode of The Brain Booster with Carl Morrison. Carl again has agreed to join us virtually, and thanks again, Carl, for joining us. And I want to take up where we left off in the last episode, where you mentioned the importance of having good days for an athlete who's maybe had a recurrent injury. So could we just chat about today the importance of good days and kind of go into that in a bit more detail?
Yeah, I think if you look at it, to me, Dave, success in anything, whether that be winning trophies, winning tournaments, winning leagues, or getting back from recovering from injury, is about the quality of the days that you put in. If you accumulate enough good days, I'm not saying success is guaranteed, but you massively increase the chances. And the problem that we all have is that we don't focus enough on what I'm going to do today, and we get too drawn into what's going to happen way off in the future. We've seen it with teams who get way ahead of themselves, of winning championships and things like that. You know, with injuries, it might be a past history that you've got, and it comes back to now, the key thing with accumulating a good day is to understand the importance of beginnings and endings. Mentally, beginnings and endings are everything. If you think about films that you remember, films that you tell others that are really good, I guarantee generally they may have had a good finish, they may have had a good start, but I'd almost guarantee that they've got a good finish, because we remember the beginning and the end of an experience far more than the middle bit. So with that in mind, to accumulate a good day, you know, one ritual I think so important for anybody is to start the day with what I call intentions. That you get up in the morning, you actually write down 2 or 3 things that you intend to do today. Now, it might be 2 or 3 things that you intend to do to assist your injury, to assist your recovery. The key thing then is that if then you do those things, those intentions become completions. So that at the end of the day, you look at what you'd written down, you tick it off at the end of the day, and that feels good today. And you actually then become the sort of person who does what they say they're going to do. And that, to me, is the heart of self-confidence. If you actually do what you say you're going to do, there's a tremendous boost from that. There's a tremendous sense of self-efficacy with that. And I think this is where the therapist becomes a coach also. I think to just, as we've talked a lot about this, to just deal with the actual injury is only half of this. Where a great therapist is giving strategies to help that player do things away from the clinic. So you're actually, great physio is also a great coach. You know, we've discussed this many times. The work that we did it with the Giants all those years ago. You know, you were coaching players as well as being the therapist. You know, and I think it's a very, very big distinction for physios to make to really go to that next level of what they're actually offering beyond just injury recovery. Yeah, of course, that's a massive thing, but it's not the only thing. We've got to look at the whole system.
Carl, once again, that was absolute gold. And just what you said there, any therapist, I know we mentioned sport a bit there, but any therapist working with persistent pain patients, and I'd like to touch on this on the next episode if it's okay with you, their confidence is being shot. And that's with a lot of sports athletes as well. So in the next episode, we might chat a bit more about confidence, but you've just given us the blueprint, so to speak, of how to build that confidence back with easy applicable steps, and we'll chat about that in the next episode. So, Carl,
that's the key. That's the key. Sorry, just to interrupt, David. That's the key point. You know, we can't win the trophy today. We can't transform the injury today, but we can have a good day today. That's the key message. And if you add those up, if you accumulate those good days, it really is surprising what can happen.
Brilliant. Thank you very much, Carl.